Hello, good evening, good afternoon, or good morning. Welcome to our ESGE webinar paper of the month. Today we have again two wonderful papers selected, and it's my pleasure to welcome you with my friend Peter Siersema. We are still friends, although we had yesterday an exciting football match, and it was 1-1, Peter. So I think we can both live with this result and hope the World Championship will show which team is better, but this is not our topic right now. We both selected two really great papers, I would say, and have also invited experts who will comment these papers. And at the end, you as expert watching our webinar are welcome to ask questions. As you know, we do this webinar since more than 5 years now. And I think it's a wonderful, meanwhile, event, always Wednesdays, to interact with our endoscopy society. So please use the Q&A boxes for questions. So each presentation will take 10 minutes, and the expert will comment the papers. And at the end, we will have a discussion with you to this paper. And the first paper I would like to introduce is a paper on upper GI endoscopy from a Polish group. It's presented by Władysław Januszewicz. He is working at the Department of Gastroenterology and Hepatology and Clinical Oncology in Warsaw, and his boss is Professor Jarosław Regula, a good friend of mine, which I know since a long time. And they did a fantastic study on upper GI endoscopy and missed cancers. We all know about the problem of missed cancers in colonoscopy, but we do not know very much about missed cancers in the upper GI. And I think it's now a really interesting study, and I would like to start with the presentation. Vlad, now the floor is now yours, and please demonstrate us your study from Poland.
Hi everyone, my name is Władysław Januszewicz. I am based at the National Institute of Oncology in Warsaw, Poland, and I am very pleased to present you our study entitled Clinical Characteristics and Risk Factors of Upper Gastrointestinal Cancers Missed During Endoscopy, a nationwide registry-based study. I have nothing to declare. So, as you are all aware, gastrointestinal endoscopy contributes a major clinical service, and the demand for it has been constantly increasing. This is US data showing that the use of endoscopy has increased over 50% in the time frame of 10 years, and nearly 7 million of upper GI endoscopy were performed in 2009, which is a number that is surely much higher these days. And for such a widely used procedure, as a healthcare provider, you want to ensure a highest quality standard. However, in terms of upper GI endoscopy, the performance is not ideal, and the amount of missed upper GI cancers of over 11%, as shown in this meta-analysis, is quite concerning. There have been several studies which addressed the issue of missed upper GI cancers. However, these are mostly single institutional studies with quite small cohorts and a widely differing methodology, which also leads to quite heterogeneous results of the missed upper GI cancer rate. And also, most of the studies were not powered enough to provide evidence for risk factors of missed upper GI cancers. To somehow fill this gap of knowledge, we performed a large nationwide registry-based study, and we used two major databases, the National Health Fund Registry, and just to let you know, most of Polish population, namely 90%, is reliant on public healthcare, and this registry registers all the procedures performed within the public healthcare service. A separate database is Polish National Cancer Registry, which is a separate database just focused on registering cancer cases within the country. We screened adult patients who underwent upper endoscopy, and we've identified those who received a diagnosis of upper GI cancers, and we've only included those cases that were kind of both double reported, both in National Health Fund Registry and Polish National Cancer Registry, to provide the most robust cancer diagnosis. As per previous studies, the definitions of prevalent and missed upper GI cancers were as follows. The prevalent upper GI cancer was a one that was diagnosed within 6 months after upper endoscopy, and a missed cancer was a upper GI cancer that was diagnosed within 6 months up to 36 months after a so-called non-diagnostic endoscopy. So this is an example of such a case. Let's say a patient had endoscopy in 2011 and received a diagnosis of upper GI cancer in 2013. This is 2 years, so this fulfills the definition of missed upper GI cancer. And we've analyzed the data both for primary care endoscopy units and secondary care, so hospital-based endoscopy units. On the whole, the aims of our study was to evaluate the prevalence and clinical characteristics of upper GI cancers missed during an upper endoscopy, and to identify the risk factors for these events. This is an overview of our cohort. We've screened over 4 million individuals. Most of these were female patients, and not surprisingly, the majority of patients were resident of urban area, and this is most likely due to a better availability of endoscopy service in urban areas as compared to rural areas. This map reflects that throughout the provinces of Poland, the percentage rate of the population that took part in the study was relatively uniform, meaning that this was a true pan-nationwide study involving the whole population of the country. Now I want to walk you through the study flowchart. So as I mentioned before, we've screened over 4 million patients who underwent nearly 8 million upper endoscopies. We then filtered those patients through National Cancer Registry to show that over 33,000 upper GI cancers were diagnosed within our cohort. And of these, nearly 2,000 cancers, which stands for 6%, fulfilled the criteria of missed upper GI cancers. This graph shows nicely how the utility of upper endoscopy has been increasing in Poland in a linear fashion, you might say, and appreciate that in 2019, over 1 million of upper GI endoscopies were performed within just the public healthcare service. However, despite the growing utility of upper endoscopy, the cancer miss rate did not really improve throughout the years, and it was fluctuating between 5 to 7%, and on average it was 6%, as I mentioned before. However, it was not changing, it was relatively stable throughout the study period. This is quite a busy table, but this is just to show you a few most important differences that we showed between patients with missed upper GI cancers and prevalent ones. As you can clearly see, the patients with missed upper GI cancer were more commonly women, had a higher mean Charlson comorbidity index score, and more often their index endoscopy was performed within primary care endoscopy unit rather than secondary care endoscopy unit. And finally, and not surprisingly, a higher fraction of patients with missed upper GI cancers presented at with an advanced staged disease as compared to prevalent upper GI cancers. A multivariate logistic regression model just confirmed our initial findings, showing that the female gender and index endoscopy at the primary care unit were kind of equally powered risk factors for a missed cancer diagnosis. And almost in a linear fashion, a growing Charlson comorbidity index was associated also with growing odds of a missed upper GI cancers. And lastly, we looked at the most relevant free histological subtypes of upper GI cancers, namely esophageal squamous cell carcinoma, esophageal adenocarcinoma, and gastric adenocarcinoma. And we clearly saw that the rate of missed esophageal adenocarcinoma specifically was the highest among the free histological subtypes. So I would like to conclude that upper GI cancers were missed in approximately 6% of upper endoscopies performed within the Polish public healthcare system. Among these, esophageal adenocarcinoma was most frequently missed subtype, histological subtypes of upper GI cancer. And missed cancers occur more frequently within the primary care sector and are found more often in women and individuals with multiple comorbidities. I would like to thank you for your attention, and I'm happy for your questions. Thank you very much.
So thank you, Vlad, for this excellent presentation. And now it's my honor to introduce our expert on this field who will comment this paper, my co-worker, Dr. Alana Ebigbo. He is an expert in upper GI endoscopy and interventional endoscopy, doing a lot of research on AI and Barrett, and was trained by Dr. Oyama. He's also doing right now or planning a study for upper GI screening in Germany. And I think he has a lot of experience to comment this paper and to have some ideas how we in Europe can probably decrease the number of missed rates. Dr. Ebigbo, please.
Thank you very much for the invitation. Thank you, Vlad, for this beautiful presentation of a really excellent and exciting paper. I'd like to comment on it. First of all, let me talk about the strengths and, in my opinion, the most significant contributions. First of all, I want to stress to the audience what it means, the amount of data that was inputted into this study. The data is extremely robust. We have a huge number of procedures and patients. More than 5 million EGDs and more than 4 million patients were screened or were included in this. And that's the second point, in this double reporting. The study correlated to high quality nationwide databases in Poland and included only patients that appeared in both databases. This point cannot be stressed enough, which means the data is extremely robust. Second point that was striking to me is that the study produced data not just on gastric cancer or on esophageal cancer, as in many other studies, but included all upper GI cancers. And Vlad has already showed the missed cancer rate for squamous cell, esophageal adenocarcinoma, and gastric cancer. Interestingly, and I'll come to that later, this is also a key finding, esophageal adenocarcinoma was highest in the missed cancer rate. The third point, which was very interesting to me, is if you look into the paper and look at the graphics, the number of EGD procedures being performed is rising. And we know that our technical abilities are improving. We have better endoscopes, but the missed rate remained constant over almost 10 years. This was very interesting to me. So next point. But where there are strong where there are strengths, there are also a few limitations. These limitations include, number one, and they are mentioned in the study manuscript as well. Number one, there is some background information missing. For example, indications. The indications were not included in the patients that showed missed cancers. So it would have been interesting to me to understand what indications were more or less often associated with these missed cancers. Also, screening or surveillance endoscopies were not differentiated. It was differentiated therapeutic or diagnostic, but if I understood correctly, screening and surveillance endoscopies were not included. So it would be interesting to understand what could be the role of screening and surveillance. Second point, the procedure time. Take the one of the key points. Outpatient procedures had primary care units had a higher missed cancer rate. We know that primary care units may be under more time duress. And also interestingly, esophageal adenocarcinomas were more often missed. And we know from, for example, from a paper by Gupta published some years ago, that the inspection time for Barrett's is very important. We need about 1 to 2 minutes for 1 to 2 cm of Barrett's. Could it be that because of the time strain, we were missing some more of these esophageal adenocarcinomas? The third point, and this would be very interesting, probably something that can still be worked upon, is the image data. Is it possible to still get some of these, get at these image data? Because it would be very interesting to understand how the endoscopic appearance and the morphology of these missed cancers were when they were missed, because that would produce a learning curve or a feedback learning. Also understand where the exact location of the missed cancers were, not just distal and proximal, but for example, under the angulus fold. Next slide. So Vlad, let me direct some questions at you. First of all, as you know, we do a lot of Barrett's and also Barrett's with AI in Augsburg. So I'd like to ask, and many of the cancers missed, a greater percentage of the cancers missed were Barrett's cancers, or at least esophageal adenocarcinoma. So I'm asking you the question, do you think that endoscopists in general should be trained better or should be paying more attention to Barrett's related neoplasia and dysplasias? And also in this context, do you think also in general that AI could be a piece of the puzzle?
Hi everyone. Thank you, Alana, for starting this discussion. Indeed, this is a very important issue, and surely there is a problem in high rates of missed esophageal or Barrett-related neoplasia. I want to also bring back a fairly recent meta-analysis from Mayo Clinic, from what I remember, that said that nearly a quarter of esophageal adenocarcinomas are missed at index endoscopy. Our study, I think, have another aspect to it, because I want to remind you that we are talking about Polish data. And when we look at cancer audits in Poland, still it's more of a, let's say, Eastern profile of esophageal cancer. So the majority of cancer that we have is 80 to 90% squamous cell cancer. What I'm trying to say here is that Barrett's and Barrett-related adenocarcinomas is rather an emerging issue, rather than something well-defined or established. So I'm pretty sure that our data represents lack of awareness, probably, of endoscopists for this condition. Surely there is a wave of these cancers coming to Poland, and we will see the switch of the subtype ratio. But I think that surely the importance of our report is to stress out that there is an issue in recognizing more probable lack of or underdiagnosing of Barrett's esophagus and esophageal adenocarcinoma. So yes, indeed, this is a red light somehow for all those Central or Eastern European countries that, hey, look, maybe there is some issue there.
Okay, that's interesting, because I would like to just pick up on there briefly. I can see we have some questions in the Q&A, but let me just pick up on this briefly. That means do you think that this data from Poland can be extrapolated to other European countries, and to what extent?
Hard to say, really. Hard to say. This was surely to some extent. You know, we would have to compare a true pan-nationwide kind of other studies. I think the overall miss rate should be comparable. I don't see any reason for it to be, you know, anyhow worse or better in Poland than anywhere anywhere else.
I agree. But could you just maybe make a comment on why do you think the cancer miss rate has remained constant over the years?
It's just that I think that we work at it's fair to say that most of us work in expert centers, and we see this kind of, you know, expansion of new equipment, and we have the availability to it. But I think that does not necessarily translate into what is happening outside of expert centers. So whenever, I'm pretty sure that most of you would agree with me that sometimes you go into smaller centers, province centers, and you see the same equipment that has been there for over 10 years, 20 years. So because this is a kind of true nationwide study, I think this is why it remains constant, is that this, you know, growing utility, growing experience, it does exist, but I think it's mostly confined to the expert centers, which is a shame. This is how I would conclude.
I agree. I understand your point. Chairman, please, could I just ask him my final question before we go over to the Q&A? So, because I would like to just chip in on that, Vlad, just could you give us finally, or at least myself, your recommendations? How do you think the quality of endoscopy can be improved? And also, how do you think we could work on reduction of this rate of missed cancers by training, by more technicalities such as AI? What do you think?
Yes, you know, it made me think a little bit, actually, what is the kind of best thing you can do? And of course, AI will be helpful in the future. Surely, it's an interesting avenue. And of course, all of the quality measures that we know, so photo documentation is a very important, time spent. But I think, you know, on the whole, it is most important to kind of develop a kind of uniform fashion of examining patients, regardless of the profile they represent. So, for example, we have shown that the cancer is more often missed in female patients, in primary care patients. Some studies, and actually a few of them said that it's more commonly missed in younger patients. And the probable explanation to that is female patients, younger patients, primary care patients are the ones that are less likely to have a cancer. So the attitude of the endoscopist might be, it's probably nothing, I'm just gonna go in and out. So what I'm trying to say here is that developing a uniform fashion, when you do a kind of thorough step-by-step examination and truly examining every spot in the stomach, in the esophagus that you possibly can, just, you know, base 1, base 2, base 3, base 4, and remaining this uniform fashion for everyone without exception. I think just being constant with it is the way to go. So it's more of a, like, you know, a mindset change and attitudes change, of course, along anything else, meaning, you know, photo documentation, all the other quality measures. But I think the mindset is very important here as well. and just remaining constant kind of performance.
Okay, well, a lot of interesting questions, burning questions, which also covered the questions partly from the Q&A. Though I thought the cancer miss rate which did not decrease over the time. This is also a question from the audience, or what is the role for AI? I'm wondering, and this was also was Dr. Bigbo was asking you, what is now the recommendation, and how long should a upper GI endoscopy take time? What is a recommendation? Probably you didn't stop the time during, it was not possible, but how long does in your country, how long does an upper GI take?
It really depends. It's you know, from the papers we know that, you know, the best time frame is at least 7 minutes of examination time. This is what probably only study that we have so far. You know, we do not have any recommendations for the time inspection time in upper GI, and this is a huge issue. You know, this is also another issue, that there are no recommendations on it or whatsoever.
We always hear from our Japanese colleagues, they find so many subtle lesions, and we think it takes hours to inspect the stomach, but in Japan, they also examine the upper GI within 7 minutes. So I think one key message is you see only what you know. So training must be very important. It's much more important than in the colon. In the colon, I think it's not so, but you have so many differential diagnoses in the upper GI tract, and you really can see what you have been trained. Otherwise you're lost. And an interesting question from the Q&As, does anesthesia play a role? We know from screening colonoscopy, sedation obviously increases adenoma detection rate. Did you also had data on this topic?
Yeah, this is something we've included in the limitations, that we could not reach any information on the sedation use. But what I can say is that you know, from experience and from kind of the healthcare knowledge, my knowledge on our healthcare, is that the vast majority, and I'm saying, and I think about, you know, 80–90% of upper GI endoscopies in Poland are done with just the throat spray. So I think it's fair to say that this data that we show, you know, is for unsedated upper GI endoscopy. It might be that those, you know, procedures performed in secondary care are more often being under sedation because it's a hospital setting. And this is why also another explanation why the miss rate was higher for primary care. But of course, it is just an assumption. I cannot say that this is a kind of strict outcome or you know, because we don't have data for sedation. We can just assume that this might have been a factor as well.
Okay. And we have one last question from the audience and one last question from Peter. Maybe Peter first.
Well, I think it's also important to mention that we have now these quality improvement standards that have been formulated by ESGE and published in Endoscopy. Would that help also improving the quality of endoscopy in the sense that also the miss rate will decrease? Or is that not the final solution for this?
You mean implementing the...
Exactly, yeah.
Well, surely. I mean, this is what we do it for. So yeah, absolutely. But it's just, again, you know, we do those online meetings, online seminars, and I'm afraid that you know it depends on who you reach. You know, because I'm pretty sure the problem is that we only speak within expert centers, and we don't often kind of reach the smaller units, the most peripheral units, with those guidelines and recommendations. So as long as we improve a small proportion of endoscopies being performed in expert centers, there's still you know, a large kind of field left behind. And I think this is the biggest issue, is to how to, you know, how to reach those smaller units with the knowledge and kind of experience. So this is
one last question from the audience is the question of a transparent hood for a cap on the gastroscope as we use it for colonoscopy. Do you think it's worth to use it to decrease the number of missed cancers?
You know, I think for general kind of endoscopy practice, it's not obligatory to use a cap. You know, it's at operator's discretion where to use it. Of course, so I use it myself when I know there is Barrett's, when I know there is a lesion I want to have a closer look at. But for the general practice, I think it's not necessary.
Okay. Well, great. So thank you both. Wonderful presentation of your paper and critical questions from our expert. So thanks a lot. And now we move on and
thank you so much.
To Peter, it's yours.
Well, thank you, Helmut. Yes, the next topic is, I think, a very exciting topic because it's about the environmental footprint of endoscopy. And we notice this difference in climate every day. For example, tomorrow there's snow expected in the Netherlands, and that is very unusual. And of course, that could be one of the consequences of the environmental footprint of everything we do, but maybe also of endoscopy. And that's actually the topic also of a paper that is already published online, and it will be presented by Daniel van Rentelen. He is from the Department of Gastroenterology in Montreal in Canada, and he performed together with the center, with the Department of Gastroenterology at Dartmouth Hitchcock Medical Center in the US, a study, and they estimated the environmental impact of disposable endoscopic equipment and endoscopes. Daniel, the floor is yours.
Hello, everyone. It's a pleasure being here. I would like to thank very much the organizers for inviting us to present our paper. I would like to present on behalf of our group of co-authors the study estimating the environmental impact of disposable endoscopic equipment and endoscopes. We tried in this study to measure the environmental impact that our endoscopy practice has on waste generation, which is then closely related to greenhouse gas emission. And our healthcare system is responsible for 4.4% of the total greenhouse gas emission worldwide. In the US, it's even higher. It's about 8% of the total greenhouse gas emission. Greenhouse gas is a major contributor to climate change, and climate change affects human and GI health. The emission we're creating with endoscopy practice is related to production, transport of medical supplies, in addition to energy consumption associated with medical procedures. So what do we know so far? We are all aware that we use major amounts of single-use instruments and material to perform our procedure. Because of sterility and safety issues, we use single-use mainly. And we have a very high caseload, meanwhile, of annual endoscopy procedures. In the US, it is estimated that there are 18 million GI endoscopy procedures per year. What is unknown so far is the quantity of waste that generates and what the environmental footprint that might be associated with our practice. So what we try to do is quantify the waste generation associated to endoscopy practice in a high and a low volume hospital. We conducted a waste out audit for 5 days in 2020, still in the pre-pandemic time, and we documented mass and volume in the procedure rooms, but also in the pre and post-procedure area and in the high volume hospital in the reprocessing area. We measured mass in kilogram and volume in 20-gallon or 76-liter containers, and later then to present our results, we're going to conceptualize that in comparison how many one-passenger automobiles that would create in mass of waste generation, or how many soccer fields we can fill up with waste because of that yearly practice. And we try to categorize the waste that is generated into general waste, biomedical waste, and recyclable waste. We calculated the average quantity and procedure-related quantity at each hospitals, and we explored what this would mean based on the US volume of endoscopies per year. And we also tried to consider what would happen if we shift to single-use endoscopes for no procedure compared to only using it for colonoscopy and ESCPs, or if single-use endoscopes would be used for all GI endoscopy procedures, and what that would mean for the waste generation and potential increase in waste generation. So what we found in this 5-day audit, that we conducted 278 procedures in 243 patients in both hospitals, and the vast majority of these procedures are colonoscopies and EGDs, and ESCP, EUS, sigmoidoscopies only make up for a small fraction of that. That means in these two hospitals, we have about annually 15,000 procedures per year. And the total mass we measured associated with these procedures was 546 kilogram. Higher mass in the high caseload hospital, and in average, we have a mass of 2.11 kilogram associated in waste with each endoscopy procedure. We found that the majority of that waste is general waste, smaller percentage biomedical waste, and then very small percentage only of recyclable waste. And the same here for the volume, high volume associated with all the procedures, 271, again, a bit higher volume in the high caseload hospital. And the same here, the highest percentage of volume, again, general waste, biomedical waste, lower volume, and recyclable, a bit higher volume than the biomedical waste. And interestingly, if we look on details at the of the general waste, the majority of general waste is plastic or is composite material with plastic. Only a small percentage metal, paper, or fabric. That being said, likely there's a lot of this plastic that could undergo recycling, which is not exploited yet to really reduce our environmental impact in the hospitals. And if we look at that, what it means contextualized in mass and volume, according to all procedures done in the US. So we estimate that we can cover about 117 soccer fields with waste to 1 meter depth with the waste generated during endoscopy procedures per year in the US. And it would be a mass and a weight that would be represented by 25,000 passenger cars thrown away in the US as waste. And what we can find, if we increase our use of single-use endoscope, we will increase our waste generation. If we only use colonoscopes and duodenoscopes, we increase our waste generated per year by 25%. And if we would perform all endoscopy procedures with single-use endoscopes, our waste would be increased by 40%. So that's quite significant. So the study quantifies waste in mass and volume generated by endoscopy procedures per year. And the previous data indicated that we create about 1.5 kilogram. We found in this study that it is more 2 kilogram, a little bit above 2 kilogram. And it's the first study to take into account pre and post-procedure area for waste generation. And this was still pre-pandemic, so we found an 8% of the overall waste was personal protective equipment. And we assume that meanwhile this has increased, which also will have likely increased the overall waste generation per endoscopy procedure since the pandemic has started. And we also identified there are obstacles to recycling. There's a discrepancy between what is recycled and what could be recycled, and there's a large potential for improvement here. Limitations of the studies are that this is only a 5-day audit at 2 hospitals. Is the sample representative? There is a different practice. Some hospitals use single-use gowns, others use reusable gowns. So there is a certain shift from one place to another, and we should measure that and to have a better understanding how representative our findings is. And there's still a certain uncertainty with the volume, because how much we compress the waste will influence the volume very much. And we will need to further measure what is the real CO2 output associated with that practice. So that's all part of future studies. However, it is clear that GI endoscopy practice has an environmental impact, and considering how high the impact is of our healthcare system, it is relevant. We generate about 2 kilograms of waste, excluding the reprocessing during an endoscopy procedure, and that is equivalent to 25,000 single passengers cars or 120 soccer fields covered with 1 meter depth of waste. If we shift to single-use endoscope, we will increase our waste generation. And if we do all procedures as single-use endoscopes, we estimate that it would increase by 40%. And we do need to do further studies implementing change, implementing recycling practices, and also look into how we can really reduce or optimize that endoscopy-associated waste generation. And I think the ways to get there is to work together with companies, GI societies, hospital administration levels, and also on the individual level as physicians. We have a responsibility here to contribute to a solution for CO2 emission that occurs in the hospital. Thank you very much.
Thank you very much, Daniel, for this excellent presentation. And I think very important information that we need to know when we are performing endoscopy. This paper will be commented by Enrique Rodriguez de Santiago. He is from Madrid in Spain. He is also chairing the positions, the ESGE position statement paper on this topic, and he will comment this paper today.
Thank you very much, Peter, for the introduction and for the invitation. And congratulations, Daniel, for this excellent presentation. It makes me very happy that Peter and Helmut chose this paper and that it was published in a high-impact journal, because it means that sustainability is becoming a topic of interest for gastroenterologists and for endoscopists. Here is my conflict of interest. And the first question is the topic relevant? There is no doubt. Climate change is an undeniable reality. CO2 concentration in the atmosphere is higher than ever. And as Peter said, we are witnessing an increasing frequency of extreme weather events. Global temperature is expected to increase by 4 to 5 degrees in this century. And it is highly likely that the ice in the Arctic Sea will disappear during the summer season in the next 10 years. On top of that, climate change has a negative impact on health, and it will increase the incidence of cardiovascular, respiratory, and infectious diseases. Healthcare activities do have an environmental impact and contribute to climate change. It has been estimated that healthcare activities account for about 4 to 6% of greenhouse gas emissions, and this figure goes up to 8% in the USA, where the study was conducted. So without question, I dare say that this topic is relevant. I think that this is a wake-up paper. I think that, or from my perspective, the main strength of this study is that it raises awareness. It highlights that GI endoscopy produces a huge amount of waste, that our activity has a significant impact on the environment, and that we must care about it. The second key point is a warning about the widespread use of single-use duodenoscopes, because they have a high environmental burden. It goes without saying that as clinicians, we should prioritize patient safety in terms of infection risk, but we should also balance economic, environmental, and societal cost. And currently, many authors and even scientific societies support that maybe our goal should not be zero infection risk, but an infection risk as low as reasonably practicable. And this paper tackles the question of waste generation, but it does not address the problem of waste segregation and waste processing and disposal. A survey was published 5 years ago, and it found that most members in the endoscopy unit do not know how to segregate waste. It is very common to mix biohazardous and non-biohazardous waste, and also most of the endoscopy staff felt that more education and information is required. There is a high rate of inadequate processing and waste disposals, even in developed countries. Currently, recycling rates are low, and we cannot forget that incineration and the waste disposal in landfills are activities with a high cost, and they are very polluting. And I want to show some pictures from my unit. You can see some bananas mixed with paper box, and also some plastic and some paper that could be recycled, but that are inside and being dedicated to biohazardous waste. And I feel that probably this is not only a problem of my unit, but that this also happens in other hospitals. But the truth is that waste is only a small part of the problem. From my perspective, maybe a more accurate title for this paper would be estimating a tiny part of the environmental impact. Currently, there are few data about the environmental impact of GI endoscopy, 6 studies. And what do we know? We know that GI endoscopy is among the top waste generators, the generators in healthcare facilities. It has been estimated that we released about 5 kilograms of CO2 per endoscopic procedure, which is a lot, and that we relieve about 300 grams of CO2 per biopsy sample. Also, a study that has been published as an abstract suggests that single-use duodenoscopes release 20 times more CO2 than reusable ones. And when we look at the data, the literature, we can find 2 types of studies regarding the use of single-use endoscopes, mainly duodenoscopes. We can find cost-effectiveness analysis, and in general, they support that single-use duodenoscopes are more cost-effective from an economic perspective, but they consider a very high rate and somehow unrealistic endoscope-related infection rate. They consider a very high cost of infection treatment, and the truth is that no independent studies have been conducted so far. Regarding clinical studies, we mainly have feasibility studies, but we lack head-to-head studies focused on infection risk. So in summary, currently there is no good data to support that single-use duodenoscope reduces the risk of infection. The truth is that at this moment, we don't know, or it has not been estimated, which is the true environmental impact of our activity. We need to perform dedicated research that take into account the impact of endoscope, endoscopy accessories, infrastructure, educational activities, medication, and so on. In summary, we need to consider direct and indirect environmental impact of GI endoscopy. We also need to investigate on how to reduce our carbon footprint. We have to perform more research, and we have to take action in very different domains. For example, what can we do to reduce the carbon footprint with our clinical and endoscopic management? For instance, we have to reduce the current rate of unnecessary endoscopic procedures, which has been estimated to be 30% according to recent meta-analysis. We have to implement sustainability in the design and functioning of the endoscopy unit. And as Daniel said, we need help. We need that industry and all agents involved in the healthcare chains become green and behave in an environmentally sustainable way. I would like to finish by saying that it is not too late. Current data show that a drastic reduction in CO2 emission can slow down climate change. And if you feel that you want to know more about this topic, I invite you to read the upcoming position statement from ESGE and ESGINA that hopefully will be released in May. And also another good reason to attend to ESG Days is the Green Endoscopy session, which will be held on Saturday, and you can join us virtually or you can join us in Prague. Finally, I would like to discuss with Daniel some questions. First, Daniel, We know that there are several things that can be done, but to be more specific, what would you do tomorrow in your endoscopy unit to reduce your carbon footprint at work?
Thank you so much for these nice comments and all these additional points, Enrique. It's really fantastic, and also thanks again for the invitation to present this paper. Yeah, I think the time is still there that we can do something, and I hope that we can contribute to that and still continue doing endoscopy and provide great patient care. So it's a very good question. What could we do immediately? And I think what comes to mind now and what I'm trying to do is having a look what procedures are necessary and what not. So it's pretty clear that a fit test will have a lower CO2 footprint than a colonoscopy procedure. You know, recycling is all nice and we need to implement, and we need to talk to hospital administration. But what we can do, we can make decision. Can we replace an exam with a lesser waste generating or CO2 footprint exam? And I think going for an average risk screening patient after normal colonoscopy, going back to fit testing instead of doing colonoscopies, that's one thing. Second thing would be check the surveillance intervals. Are they correct? One of our studies here published a paper 3-year in endoscopy. More than 50% of our surveillance intervals are scheduled at the wrong time point, and most of them are scheduled too early, meaning hyperplastic polyp patients are typically seen in 5 years instead of 10 years. You can also move to the newer guidelines, moving low-risk polyps to 10 years. And even some guidelines like Ontario guidelines recommend even low-risk patients sending them to a fit test for follow-up instead of a colonoscopy. So I think these are the immediate things we can do. And then what you said, we need more data on what infection risk is really, you know, how much do we need to gear up? Do we still need to gear up in the, you know, like in March 2020, where we were, you know, all in these space suits? Do we need that, and where can we reduce the PPE? I think that's meanwhile a driver also of creating more waste.
Completely agree with what you said, Daniel. I would only add 2 more things. Maybe to be very selective with biopsies. We saw that 300 grams of CO2 per biopsy. And also another way to reduce our carbon footprint is by choosing the less resource intensive technique. In other words, if you can remove a polyp with cold snare, maybe better than ESD or hot snare, which requires using injection, using the electrosurgical unit, and so on. Okay, and my second question, this is something that worries me a lot. I think we lost the war. I think there is no way back to reusable devices. But do you think that is it sustainable and all single-use policy? We live in a single-use society. Is it possible to keep on single-use endoscopy for everything?
Well, yeah, I think you're right. It's hard to turn back, you know, the time here, and we would have to really measure what's the difference. And we're trying now in a second follow-up study, to measure what is really associated in CO2 footprint with each procedure, and what can we do then by moving back here at our center to reusable gown. That's one thing for follow-up study we do. We did a first study, okay, single-use gown, what's the waste generation, what's the footprint, what happens if we replace everything we can with reusable material. And then we have to see what it means. Are we reducing? I think we're going now more towards 2.5 kilogram after the pandemic and the additional PPE use. Can we go back to 2 or 1.5 kilogram, or is the impact much less than we actually thought? And to really calculate that the same, what happens if we replace 5,000 procedures with fit testing a year? So that would be interesting things to ask.
Yeah, okay. I think maybe we should also demand to industry carbon offset programs and sustainability in the whole.
A good point is what you said. If we move to single-use endoscopes, that's the fastest way to increase. You know, if we now change our whole endoscopes plus the packaging around it. And so that's the fastest way to really dramatically increase our waste generation and CO2 footprint.
Okay, and last question regarding waste. What is more important, reusing, or maybe recycling?
I think everything should be done, and everything is great. I think the biggest savings we can do by reducing procedures or replacing procedures with non-waste or non-CO2 generating procedures. Recycling, as we see in other areas, are always fraught with some complication, especially in the hospital system, where we need to be careful not to create infection chains and really find first a way what is really recyclable, what has been, touched by some, saliva or anything contagious fluids, and to make clear what can we recycle and how are we doing that. But what you said is right, to contact companies, reduce the packaging material around endoscopy equipment. It's sometimes the boxes are incredibly large.
Completely agree with what you say, and I think it's important to highlight that we should focus the attention maybe on reducing rather than recycling, because the benefit is less than with the first measure.
There's some comments also in the Q&A box, some technical comments, and one is what is the effect of sterilizing instruments? Is that also is it a positive effect, a negative effect? Can you balance that in this discussion? And maybe this question to Daniel.
Yeah, it's a good question and good point to further evaluate. I don't think we have enough data. I think what you saw right now in this wake up paper, it's very rough. It was like 5 days just collecting all the waste and looking what that is. And now in the follow-up studies, we're going into the details. What is really created where? What is the percentage of PPE? What is the percentage per procedure? And then also looking into what are our reprocessing structures and how much is created there. And what Enrique said, the waste is only a small percentage. Again, like what is the heating and how does it link together in the overall ecosystem of a hospital? But it's something we will have to look into further.
Yeah, and there's also another question related to that, and that is the use of CO2 that we are increasingly using. I wonder, is that really an issue, or what do you think, Enrique? Do you have an idea on that?
Okay, yeah, we were discussing about this, and quantitatively, this is not a major issue in endoscopy. It has relevance, but from a quantitative perspective, it is not, because we don't use such a high volume, and the CO2 is captured from the atmosphere before. So I guess this is not the major contributor or the major polluting of our activity.
Well, then maybe a question for the two of you, based on on the impressive data that Daniel presented. Are you guys optimistic in the next few years? Are we going to make any progress here? Maybe first, Daniel.
Yes, I mean, I think it's going to become so much more pressing, and we look up the newspaper every day and see all of a sudden, I think it was just in the Guardian an article that at the Antarctica they had 40 degrees more than what was usual for this time of the year. And I also just saw in the New York Times there was an article to say, like, if we say, okay, we can't do anything, that gives you permission, to just ignore it, and that's not an option either.
This is a very good question, Peter. I'm optimistic, but I'm realistic. I have to be optimistic because otherwise there is no reason to push the position statement. But we have a long way ahead. The truth is that it's impossible to mitigate all the side effects of climate change. But as I said in my last slide, if we make a change, we can change the current situation. But I have the feeling that we cannot wait. It's something that we have to start to care about it tomorrow. We have to start.
Well, it's good to hear that the two of you are optimistic. I think we need to be optimistic, and we need to improve here. That's definitely the lesson from what we've heard tonight from the two of you. I don't think there are any more questions that we need to discuss because I do think that everything that's in the Q&A box has been discussed already. I'd like to thank the two of you, and of course also the other two speakers for being with us tonight. I think very interesting presentations. Still some remaining questions that need to be resolved, but we will definitely do, of course, in the near future. I also like to thank my co-chair, Helmut Messmann. This is always a pleasure doing this. It's also a pleasure selecting the papers for you and discussing them. So we will do this again in May. There will be another paper of the month session. We have some final slides, which I'd like to share, some household comments. ESGE days. Early bird registration deadline has gone a little bit further in time, so it's now April 12th instead of March 12th. So you still have time to be an early bird register. Next slide, please. What is important is of course that if that these ESGE days have a lot of activities, live endoscopy sessions, interactions with other societies, hands-on training for the younger people, but maybe also for older people. And of course, you will meet your friends over there who you have not seen for a long time. And I hope that most of you will come, of course, to Prague and will be able to join us and see us over there. Next slide, please. What is the advantage of being a member of ESGE? Well, you can see it over here. Fellowships, ESGE days, guidelines, but of course also endoscopy journal. Maybe that's by itself already a pleasure. And finally, the last slide. And that's of course that this membership is even cheaper than it was before. For 150 euro, you have a dual membership. And of course, next week we have the next webinar, Diagnosis and Management of GI nets and what every endoscopist needs to know in 2022, with 3 excellent speakers in this field. So thank you very much again, and I wish you a very happy evening. And look forward to see you next week again. Thank you.
And thank you to David and Gabi behind the
Thank you.
working in the background. Thanks. Good
Bye-bye.
evening. See you soon. Bye-bye.